right, welcome back everybody. We're going to get started again. So our next presentation is by Dr. Nirav Pandya. Unfortunately, he is not able to be here for his lecture, but will be, barring technical difficulties, joining us for the Q&A afterwards. Dr. Pandya is a pediatric orthopedic surgeon and sports medicine specialist within the Department of Orthopedic Surgery. He's a vice chair of pediatric operations and section chief of the Division of Pediatric Orthopedics. He received his undergraduate degree from the University of Chicago and received his medical degree from the University of Chicago Pritzker School of Medicine. He then went on to complete his orthopedic surgical residency at the Hospital of the University of Pennsylvania in Philadelphia. He served as an academic chief resident in his final year and was the recipient of the DeForest Willard Award for Outstanding Performance. He then completed a fellowship in pediatric orthopedic surgery at Rady Children's Hospital in San Diego, where he was awarded the Lena Sefton Clark Endowed Fellowship Award. He's authored multiple peer-reviewed publications and had multiple book chapters and speaks regularly at national conferences. He also co-hosts our 6 to 8 weeks Perspectives on Sports Medicine, which presents the people and stories behind sports medicine at UCSF in our community. So without further ado, we will start his lecture.
Hello, everyone. My name is Dr. Nirav Pandya. I'll be talking about identifying and reducing care disparities in pediatric sports medicine. I have no disclosures. So really the goals of the talk are going to be fourfold. Number one, it's really important to talk about definitions. What are some of the terminology in terms that are used when talking about healthcare disparities? What's some of the current status in terms of our current workforce and the state and the way in which healthcare disparities manifest? And then we'll specifically talk about orthopedic surgery and then definitely dive into pediatric sports medicine. The first important thing to understand, you have to understand terminology before you can create change. If you don't understand the way things are defined, you may be referring to certain things in the wrong way or in a way which doesn't necessarily help to create change. We've written a great article that was several years ago in the journal, the American Academy of Orthopedic Surgeons, about current concepts in orthopedic care disparities. It's a great article that really gives you a primer in terms of what's out there in terms of literature and where we see care disparities being delivered from the orthopedic community, particularly in subspecialty areas. And this is where you can become a little bit more familiar with some of the terminology that's seen and the data, kind of looking at it more from a wholesale standpoint in terms of care disparities. Now, the delivery of healthcare is affected by multiple different factors. It's affected by race and ethnicity, it's affected by gender, it's affected by sexual orientation, and socioeconomic status. But what is that specific impact? How do each of these factors actually specifically impact the care that's received? It's important for clinicians to know as this impacts healthcare just as much as all the scientific things we look at, as much as what graft used for ACL reconstruction or what fixation technique used for an osteochondral lesion. Sometimes race, socioeconomic status, ethnicity, etc., have a greater impact on the outcome after a procedure than those other factors. So I think it's important for us to look at those factors just as strongly as some of those other quote unquote surgical or non-surgical factors that go into more of the terminology or the more the kind of the meat of what we do on a day-to-day basis as opposed to what may actually impact care a little bit more. Now, when you look at disparities, it impacts both the health of the individual and the health care of the individual. So defining what the health of the individual actually is, that's a higher burden of disability of one group compared with another. This is a little bit different than the health care of the individual, which is our differences in access to care or quality care that cannot be explained by other factors. Now, if we look at ourselves, and I'll speak more for orthopedic surgeons, we do a very poor job of understanding, number one, this is a problem, and number two, that this actually exists as a problem in our own practices. This was a survey that was basically given out to the American Orthopedic Association to basically assess their baseline knowledge of racial and ethnic disparities and their perceptions about the underlying root causes. Now, if you look at this study, probably one of the most striking things that came out was only 12% of respondents believe that patients often receive different care based on race, ethnicity, healthcare in general. Well, 9% believe that differences exist in orthopedic care in general. Very few of them actually thought that it actually existed in their clinic, and it was another problem. The fact that 12% of orthopedic surgeons thought this was actually an issue is really, really problematic and eye-opening for our community. We know very clearly that healthcare disparities exist in race, socioeconomic status, all these factors play an important role. But the fact that only 12% of orthopedic surgeons actually think it's a problem is part of the root cause of why potentially we have so many disparities in our subspecialty field. So we do horribly, and this is just one study, but if you look at multiple other studies that look at orthopedic surgeons in general, now even though there's more research being published right now, as a whole, they don't necessarily feel that this is an actual issue that needs to be addressed, which needs to be changed through the understanding of the literature and understanding the terminology and what is actually out there. Now, a lot of this has to do with who our actual workforce is. If you look at orthopedic surgeons, they have the worst diversity from a gender standpoint, with only 7% of orthopedic surgeons actually identifying as female. And then if we look at it from a racial standpoint, we see similar disparities with very low proportions of African American and Hispanic Latino orthopedic surgeons. If we look at the percentages in different rates as well too, you can see, once again, 84 to 85% of all orthopedic surgeons are Caucasian. Now, this is changing over the past several years, but once again, you still see a higher percentage, which is not reflective of the number of graduates in medical school, particularly in underrepresented populations. Now, if we look at kind of like the impact on clinical care, this was a systematic review that looked at the impact of race and ethnicity on complications and mortality after orthopedic surgery. And what they did found that patients from certain racial and ethnic minority populations were at increased risk of complications and or mortality looking at spine or joint surgery, which are two of the major surgeries that we do in orthopedic surgery. Then it's not necessarily about how race directly impacts outcomes. There's also an interplay with all these various factors. Race naturally does impact the type of insurance that people will get. And you'll see that certain underrepresented minority groups will have poorer access or poor quote-unquote quality healthcare as opposed to other groups, which are due to historical things that have been within our healthcare system and how patients have been able to access care. It also impacts access as well too. So if race impacts insurance status also impacts access to care, and race in and of itself will impact access to care when we look at a caregiver willingness to treat certain socioeconomic or racial ethnic groups, as well as their ability to navigate the healthcare system. In addition, particularly with a lot of talk now about immigration, particularly around the election year becoming more and more prominent, it's also important to understand that undocumented status will have an impact on actually going to the orthopedic surgeon or any subspecialty care as well too. There's a fear that going into this institution will actually lead to negative consequences for a patient due to their immigration status. So as a result, how it impacts care is that you may have a fracture that needs to get reduced, but they come in at 4 to 5 weeks later with a malunion or a delayed union, and having an understanding of why that patient may have presented, not because they're not compliant or not because they're not taking care of their child or their injury, it's because of their fear of something greater happening by engaging with the healthcare system. And finally, one of the things we really need to look at is also what's the perception of the healthcare system when people look back upon us. So it's important for us to reflect and say, how are we perceived among certain racial and ethnic groups? And it's important to understand that there's a lot of mistrust in certain groups, particularly with African-American communities and Hispanic Latino communities with the healthcare system. So as a result, a patient may not necessarily be non-compliant with your care or may not be willing to undergo a procedure, not because they don't have a lack of understanding, but may have a lack of trust because of how the healthcare system has treated them over a period of time. So people ask, why does this occur, right? This is a problem. It seems very basic. Why is this occurring? And the reasons are multifactorial. A lot of it has to do with implicit bias, which many of you understand what this is, but the actual definition is that it refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. Rather, implicit biases are not accessible through introspection. So you can see how your feelings non-consciously about race, ability, gender, culture, language can basically impact the care that you prescribe to patients. So if you have implicit bias as a provider, you're going to make certain judgments and decisions about patient care. That's going to lead to healthcare disparities. It's also going to impact your communication and trust with patients. So patients may be more or less willing to engage in adherent treatment, which is going to lead to disparities. So even things that you're not conscious about, certain racial or socioeconomic gender groups, it impacts the way that you're interacting with patients and downstream impacts their care. So what should we do about this? Well, we have to understand access to care. We have to understand quality and outcome of care, and we have to promote provider diversity. So understanding access to care from a first standpoint. The primary care literature is extensive in terms of delays in access to care and how it's impacted being part of a certain group. There are multiple mechanisms in place to actually access primary care physicians if you are one of these groups, whether it be a certain socioeconomic group, a certain racial or ethnic group. But subspecialty care makes these differences much, much harder because there's much more selection in terms of who is actually going to see these subspecialists and how easy it is to access care. And orthopedics is a prime example of this. So let's take a look at insurance status. There are multiple studies in the literature, whether you look at rotator cuff issues, hand flexor tendon issues, or knee arthroplasty, that demonstrate that scheduling is more complex for a publicly insured patient. There are large variations in reimbursement, which limit the number of subspecialty providers who accept public plans, and these treatment delays then lead to poor outcomes. When you look at race in terms of access to care, you see variability in providers offering care to minority populations. That can be explicit and it can be implicit as well too. And then on the back end, you're also seeing difference in patients' attitudes and expectations. There are these socioeconomic barriers that are tied to race and ethnicity, and there's a lack of patient-centered care and understanding of race, ethnicity-specific outcomes. And there are language barriers, so all these will impact care and lead to morbidity and mortality. And we see the same thing in gender as well too, although there's much less literature looking at gender. There's a lack of workforce diversity, so just as an African-American patient may be more willing to engage in treatment if they have an African-American provider, a female patient also is going to be more potentially willing to engage in treatment or have trust in the healthcare system if they have a physician who identifies similarly to them, and there's more comfort with that care. So once again, you see that as well too in spine surgery, total knee arthroplasty, shoulder injuries, etc. Now we need to look at understand quality and outcome of care in terms of how these healthcare disparities manifest. And there are multiple studies that have looked at how spine surgery basically is impacted from an outcome standpoint based on these factors. You see it in total joint arthroplasty as well too. You see it in hip fractures as well too. But in sports medicine, we have a problem as well too, both from an adult and pediatric standpoint. And you see this in ACL surgery, you see it in meniscus surgery, you see it in rotator cuff issues, you see it in shoulder instability. So let's break down how outcomes of care and various pathologies are impacted by these various factors. And let's start with ACL surgery. So if you look at pediatric ACL patients and break them down, their outcomes in terms of insurance status. This is a study that was done down in LA, and they found that publicly insured patients were more likely to have treatment delays, have meniscus injuries, and have postoperative stiffness. This is another study that was done at Children's Hospital in Colorado. They also looked at pediatric ACL patients, and they found in terms of looking at insurance status, publicly insured or patients from lower socioeconomic statuses had significant, almost 2.3 months more delay in treatment. And many of us take care of ACL patients. You can understand that 2 to 3 months of a delay in treatment can lead to more meniscus injuries, leads to more dysfunction, they get quadriceps atrophy, and their overall ability to recover from the surgery goes significantly down. We look at race and socioeconomic status, not just simply insurance. This is a study that was done at Children's Hospital Philadelphia, and they looked at Black and Hispanic and publicly insured patients. They found that these groups of individuals had treatment delays, they had more severe meniscus tears at the time of surgery, they had less physical therapy visits, and had greater residual hamstring and quad weakness. So it's not the graft that's making a difference here. It's not just the surgical technique. It's their race and ethnicity, and it's their insurance status that is having an impact on their outcomes. So if we want to optimize outcomes after ACL surgery, perhaps we should look at how we can improve these rather than just simply looking at graft techniques, fixation techniques, where we're drilling our femoral trauma, et cetera. These are huge things that we look at in terms of how patients react to pediatric ACL reconstruction. So we should have the same enthusiasm to take care of these issues as well too. This is another study that looked at access to care for adolescent ACL patients with Medicaid versus private insurance. And what they found, if you look at these patients who are basically, offices were called up and they basically looked to see, okay, can you get an appointment, can you not get an appointment, et cetera. And they found that a lot of these patients who had public insurance were not offered appointments or didn't have access to a provider for their ACL reconstruction. We also looked at this several years ago, looking at time from ACL tear to reconstruction of privately and publicly insured patients. And this is at a safety net hospital in Oakland, where we shouldn't have delays in terms of insurance status because we're taking everyone who comes in through the front door. And we had 68 privately insured patients and 102 publicly insured patients. And when we found that patients with private insurance were more able to obtain their MRI diagnosis nearly 50% faster after the injury. The time from injury to ACL reconstruction was approximately 1 month shorter for privately insured patients. And when we looked at these patients clinically, we found that medial meniscus tears and condyle injuries trended towards being more common in publicly insured patients, and lateral meniscus repairs are more prevalent in publicly insured patients. These trends also hold true with adult ACL as well too. This was a study that looked at ACL injury and access to care in South Florida, and does insurance status actually play a role? And just like with the adolescent study, they found that there was decreased access to care for patients who had public insurance versus private insurance, even getting in the door with practices that would demonstrate that they would be taking patients who had public versus private insurance. The next factor we're going to look at is meniscus injury. So very similar to ACL, you see many of the similar trends in terms of meniscus surgery. When we look at race and insurance status, this is a kind of a review of 32,000 patients. Female sex, non-white race, and public self-pay patients were associated with lower rates of meniscus surgery. They just weren't getting surgery for isolated meniscus tears. They were more likely to be told, quote unquote, be treated non-operatively, even though they may potentially not have been doing well. This is looking at young patients, and we found that public and uninsured young patients experienced treatment delays. This is looking at impact of insurance status on time to evaluation and treatment of meniscus tears in children, adolescents, and college-age patients. And even if you had a bucket handle tear, which is a very clear indication for very kind of subacute surgery that you need to have done, uninsured patients had a greater time to surgery. Many of them were treated non-operatively. So once again, even with a very severe injury that very clearly needs a very rapid intervention, insurance status played a role. And then we look at rotator cuff. Let's go to the upper extremity. This is another disparities in care study that looked at basically arthroscopic rotator cuff care and actually found that patients with lower socioeconomic status, public insurance, or low-income zip codes were treated more often at low-volume facilities by low-volume surgeons. Once again, patients with private insurance in this other study were given more rapid first appointment and had more facilities available to them. And once again, another similar study where they were basically looking at offices and seeing if you were able to get an appointment. Once again, publicly insured patients had a much more difficult time when calling up offices in terms of getting an appointment, particularly as reimbursements are tied to all these things, particularly at private offices. And finally, let's look at shoulder instability. So access to care was more difficult with Medicaid for even things as clear as recurrent shoulder instability. Even for a first-time shoulder dislocator, if they're young, if you had publicly insured status, you sometimes just ended up in the ER, you never got treated, your primary care physician could have a difficult time getting access to a specialist, and you keep dislocating again. This was a study looking at insurance from an adult standpoint. They found that patients with Medicaid had significantly more delayed care. They had more extensive history of instability, and as a result of this, how this impacts the exact surgery they were getting, they're more likely to have more severe bone loss and have more invasive stabilization procedures. So if you had public insurance, you dislocated 10 times, you couldn't get an arthroscopic Bankart repair, you're going to a bony stabilization procedure, which has a higher risk of complications. Similarly, we looked at our adolescent shoulder instability patients here at Children's Oakland, once again, a safety net hospital. And what we found that at each time point, once again, whether it be injury to surgery, injury to MRI, injury to clinic, clinic to MRI, clinic to surgery, and MRI to surgery, there were significant delays for publicly insured patients versus privately insured patients, even when our end, from a provider end, we weren't making any differentiations in terms of how care was being delivered. But it's also understand that access in sports medicine is more complex. It's not simply just about you have an injury, there's delays on the back end, this impacts clinical care. So it's not just necessarily the pathologies, but how patients are actually treated when they're coming in. So this was a medical staff perception study that looked at how do people perceive patients' pain. And basically what they found, this was at a college setting, the patients who were African-American were kind of quote unquote perceived as having higher initial pain tolerance. This was also mediated a little bit by social class and socioeconomic status, and as a result, a lot of times patients were given different care, even though they may potentially have the same degree of pain based on their race and ethnicity. We also see this with athletic training as well too, in terms of access to care for just simply having athletic trainers in your schools. And this was done in Wisconsin. They actually found that schools without an athletic trainer available on site had more students eligible for free or reduced cost lunches. And they also had higher median household incomes in areas that had athletic trainers. So once again, for high school athletes, simply by where they go to school and the socioeconomic kind of area, or if you look at it more distinctly, like the area deprivation index of where these schools are located, actually had less likely to have an athletic trainer in a population that probably needs someone to help manage and facilitate navigating the healthcare system. And once again, another area as well too in terms of concussion, particularly among high school athletes, there's underreporting of concussions. The differences we're seeing between Black and white high school students. So we're not just looking at ACL, we're not looking at meniscus, we're looking at pain perception, we're looking at concussion, we're looking at availability of athletic trainers. All of this has an impact in terms of how we're basically going to be distributing care to our patients. Now, in terms of looking at it from more global participation level, let's look at pediatric sports participation. So we look at these injuries that are basically occurring, but from another standpoint, let's look at it from the ground level. What's happening when kids are actually getting involved in sports from a pediatric sports medicine perspective? Are there disparities that are basically existing that are impacting how kids are actually able to play sports and then impacting what their injury risk is? So currently right now, there are about 5.5 million children in school sports and 30 million children who are in out of school sports. This rise has occurred with a concurrent drop in school-based physical education, with only 29% of all high school students participating in daily physical education classes. So the problem is that you've got one group of kids who have access to all the sports. They've got club sports, they've got year-round sports, they live in an area where there's tons of opportunities. And then you have another group of kids who don't have access to club sports. Their schools don't necessarily have daily physical education classes, and they don't have an outlet because there's nothing affordable for them. So as a result, they deal with diabetes, obesity, hypertension. These other group of kids are the ones who are dealing with the ACL injuries, the meniscus tears at younger and younger ages. And the reason why this is happening is that we've shifted this culture into single sport specialization, where you have intensive year-round training in a single sport at the exclusion of other sports. And you throw in the business of youth sports, which is predicted to be a $20 to $30 billion industry in a couple of years, and you have a problem, and kids are getting left out. And if you look at it right now, it's $15.3 billion. Like I said, $20 to $30 billion over the next couple of years. Now, the issue is that 63% of parents will pay between $100 to $499 per month, with nearly 20% paying upwards of $12,000 a year. The cost per year is much higher than the average scholarship amount, and this doesn't account for the expenses from injuries. If you look at where scholarships are actually going, this was a great study that was done in the Undefeated, and what they found that college athletic scholarships are more likely to be athletes who have a higher socioeconomic status than the average student, and less likely to be a first-generation college student. So the people who are supposed to be getting scholarships aren't getting them because club sports are expensive. The only way to get noticed by a college is if you play a club sport and then go to a tournament where you can travel. So suddenly, if you've got $10,000 to $50,000 to go to these expensive tournaments and travel and play with these club teams, then you may get a scholarship. But the kid who may not necessarily be able to afford that, who needs a scholarship the most to be able to get to the next level, be that first kid in their family to go to college, aren't getting the scholarships. Project Play is a great resource for some of the disparities that exist. They had this very striking statistic that said that only 34.6% of children between the ages of 6 and 12 in families who make under $25,000 a year participate in team sports, whereas those with incomes greater than $100,000 a year, nearly 70% of them participate. And this is backed up by the Robert Wood Johnson Foundation that found that only 25% of middle and high school students from lower income areas participate in youth sports due to fees, transportation, and equipment costs. So how can you help? We've talked about what we need to do as an orthopedic community, what the impact is in terms of pathology, some general terminology. Well, we need to recognize that disparities exist within our subspecialty via familiarity with the literature. We need to provide care that's patient-centered and culturally competent, understanding the effect of factors such as race, sex, and insurance socioeconomic status on access and outcomes. We need to use resources such as the American Medical Association Health Disparities Toolkit to recognize your own knowledge, assumption, and implicit and explicit biases about your patients. You can train staff and fellow physicians in your group through cultural competency trainings, emphasize that preconceived notions of minority patients can negatively affect their interactions with the healthcare system, both in terms of access and in terms of outcomes. Ensure that language is not a barrier to obtaining care through the availability of language translators. Provide and or create patient education materials which not only account for different ethnic and racial socioeconomic perspectives, but also are sensitive to those perspectives so that increased trust and knowledge can come through. Support and even volunteer initiatives that advocate for workforce diversity, such as increased underrepresented students in medical school and in our subspecialties such as Clyde Orthopaedic Society and the Ruth Jackson Orthopaedic Society. Make a commitment in your own individual practices to see patients with Medicaid and or no insurance by working not only within your group, but also with hospitals and larger healthcare systems. You need to work with primary care providers and community health centers to enhance coordination of care, troubleshoot authorization processes, ensure that front office staff are educated on easy access for patients with Medicaid. And important from a research standpoint, collect data, see how data on race, ethnicity, pair mix, to see whether there are individual practice patterns that you can change to improve access and outcomes. Ensure that finance is not a barrier to sports participation from a community standpoint. We're all part of communities, many of us have children. Ensure that financial barriers don't prevent kids from participating. Because if they have these financial barriers, they're not necessarily going to have access to those sports programs that are so important for keeping them healthy. And on the other end, if kids are getting injured from being part of youth sports culture, because we see all these disparities in terms of what they're exposed to, making sure that those barriers, if they are able to play club sports or more organized sports, are minimized. Thank you very much, and I'll try to call in for questions. I really appreciate it. Thank you.
Is that mic working?
Yes, this mic works.
Okay.
Do you want to
Pin him. Pin him, and then.
Yep.
All right.
All right, we will open it up to any questions you guys might have.
Hold on, let's
let's unmute us?
yeah. Does that work?
Yep.
All right. Hi there, Dr. Pandya. Can you hear us?
I can hear you. Yeah, can you hear me?
Yes, we can. Can we? Magic. All right. Thanks for joining us for some Q&A. We just heard your talk about healthcare disparities in pediatric sports medicine, so we'll do a short Q&A and hopefully learn more from your expertise.
All right, do we have any questions to open it up?
While we're waiting for others to ask, I actually have a question for you, Dr. P. And so you mentioned lack of trust in the healthcare system and maybe some misunderstanding with these procedures that we're proposing to our patients. And one comment that I hear a lot from the families is that isn't my child too young to get surgery? How do you navigate that for the families to kind of make sure that they're properly counseled and educated about these recommendations?
Absolutely. I think a lot of obviously what we do is kind of developing that trust with the families. And I think number one, a lot of families are concerned about the anesthesia. So I tell them that number one, the anesthesiologists are pediatric trained. It's very safe. We're doing an individualized procedure. So I think a lot of their concerns come from the anesthesia. So I kind of try to give statistics and say, look, the risk is extremely low. One of the things I say, driving here to see me is much more dangerous than the actual anesthetic. So number one is kind of dispelling that. And then number two, I think it is reasonable for families to be concerned about getting surgery when they're done at a young age. So the first thing I tell them is that number one, the techniques we use are developed so that they're not having issues with growth. So I think that dispels that first kind of concern that they have. And then the other concern that they have is, will this need to be redone? Is this going to wear away? And I say, look, the surgeries we're doing for the most part can last them for their entire life. The biggest issue in terms of it re-injuring themselves is the fact they're going to go back and play sports, but not necessarily the procedure itself. So I think a lot of it is educating them and letting them know that, hey, this is not something we're just experimenting on kids. We do this all across the country. Here's the data, and just making them feel comfortable with the whole process.
Thank you. Any questions from the audience? We have.
I'm just wondering if you looked at any comparison data from the military in terms of these kind of sports-related, activity-related injuries, and if within the military that they still see areas of discrimination, on the unconscious bias type affecting.
Did you hear that? I can repeat it for you.
No, if you could repeat it, that'd be great.
Yes. So if you've seen data on comparing military and these sports injuries and unconscious bias kind of affecting their care. Is that right?
Yeah.
Yeah.
Yeah, there definitely are, the data in the military, obviously some of it's not published, but very similar in terms of kind of how people are perceived, how patients are perceived, and what essentially their activity goals will be, or kind of, just being hey, we can do the surgery on you because you're just, your body isn't as important as, compared to someone who's not in the military, et cetera. So I think there definitely is some literature out there for that, but very similar, particularly in terms of unconscious bias and treatment decisions, which are offered to patients.
Thank you. Anyone else? Yes, we have a question from Dr. Cindy Cheng.
I will do the microphone.
Awesome.
Absolutely.
Or you want to come here and see him in person?
Sure, Cindy.
Hi, Nirav. How are you? Hey,
Cindy. How are you? Good to see you.
Good. Hey, I know in terms of our access to patients' access to see as physicians, as PTs, we're impacted, right? Have we ever considered, or have there been thought processes, and I've thought about this in the past, about having follow-up visits with healthcare educators? Because after they hear that diagnosis or they hear that surgery is needed, it becomes like a Charlie Brown episode where everything's like wah, 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 wah. They don't hear anything else. Right. But then it's hard for them, especially if there's a language barrier or they don't have experience with the healthcare system, that they don't know where to turn, right? And then they go months because they're afraid of surgery. But how viable is that? Has that been looked at in terms of possibilities?
Yeah, no, absolutely. So that's one of the things we're actually looking at, particularly from a language barrier standpoint. I think you're absolutely right. When patients hear surgery, then they kind of shut off, and then a lot of the details we're looking at afterwards just kind of get lost. So part of it is, if patients are technologically savvy, a lot of what we're doing is we give patient education material, both in English and Spanish, to our patients. And we're looking at the impact of giving, patient education materials after the visit in Spanish versus English, and patients who get it not. But I think number one is the ABS, is very important to kind of include a lot of that detail. one of the things that we've tried to do with some of our more commonly held conditions is include YouTube videos that explain everything, as well as kind of audio files that explain that information afterwards. And then we obviously do lean very heavily on our nurses and our APPs to kind of answer and circle back with the patient. So one of the things we try to do, particularly for bigger surgeries like ACL surgery or like shoulder surgery, is then set up either a visit with them afterwards to kind of go over this education stuff, or like even reaching out with a phone call as well too. But I think it does become harder, kind of in more higher volume practices, because yes, we'll spend time for like that ACL surgery, or we'll spend time for that, bigger surgery. But sometimes even as something as simple as like a meniscus surgery or knee arthroscopy, where that information isn't provided. So I think we have to do good, particularly for families that we can identify that may have some of those barriers, is saying, hey, let's do another visit. It might even be over Zoom, or it might be over the phone, to really answer those questions and get them on board. Because I do agree that some patients will come in for their surgeries and then they're asking all these questions like in the pre-op area, and they just don't have that necessarily education. So I think it's really important to educate it, whether there is a language barrier or not, but also give them mediums where they, at their own pace, can kind of digest the material and feel comfortable for that procedure. Absolutely.
Thank you. One question over there.
I'm trying to think how to best say this. So I work mostly with underserved at a FQHC in Michigan. And I was wondering, I feel like my privately insured patients are able to get their MRIs if I order it, and my public aid patients are able to get an MRI if they fail physical therapy. And so I think, the data that you showed with timing to get MRI and also timing to get surgical intervention were delayed with various identities for the patients. And I'm just wondering what we can do, or is it, the insurance companies need to fix how they support their clients, or if you had any other ideas about that. Okay.
Do you want me to kind of summarize that for you?
Yes, that'd be great. Yeah, that'd be great.
So,
thanks. Yeah.
We have a participant from Michigan. So welcome.
Welcome.
She was talking about, differences in access to diagnostic imaging. So privately insured individuals will get them, right away, but others will need, failure physical therapy as a requirement to get it authorized. And, is there a movement that kind of working with these insurance companies on, navigating those barriers?
Yeah, I think there's kind of two levels. There's like the kind of the more global level where we need to kind of emphasize, particularly for these pediatric and adolescent patients where the injuries are a little bit more different than, say, an adult, is, saying that there's a differentiation between someone who's 35 and has a meniscus tear that, yes, they probably do need to do physical therapy, versus a 15 or 16-year-old or even a 12-year-old who, this is more of an acute traumatic issue where a delay in care can impact them. So I think it's educating these healthcare plans to say, look, the criteria should be different. And for example, even for things like that seem very straightforward, for like an ACL tear in a 16-year-old, I'd say about 5 to 10% of my surgeries, I still need to do a peer-to-peer because I want to see failure of conservative management. And I say, look, this isn't a 40-year-old, this is a 16-year-old. So I think it's at the global level, educating these healthcare plans. I think at the individual level, part of it is when you see that there's a denial because of this, it's doing the peer-to-peer. I know it takes time, but like emphasizing why this is important. It's also letting, kind of the way we also write our notes as well too, is that sometimes conservative treatment is how they define it. It's very kind of vague. So if patients have been doing exercises, they've been icing, they've been doing stuff at home, that constitutes to me that they've been doing, some conservative treatment. And then I think that the larger issue, I think, for advocating for them as well too, is that a lot of times patients will get their MRI approved and then a phone call is left, or the whole navigation of the system of how do you get your MRI actually scheduled? Because if you have a privately insured patient who has, better means, a lot of those families are going to keep hassling the MRI people like, can I get scheduled? Can I get scheduled? And a lot of times what will happen, they'll get the MRI scheduled, they'll call a phone number and not leave a voicemail, or they're not English speaking and they don't understand that, okay, now I need to communicate to get the MRI scheduled. So I think a lot of it also is the system as well too, is in terms of how you get an MRI scheduled. And I think that if we can work with our healthcare systems in terms of really defining out like how you're going to get that MRI scheduled, like who's going to call you
once it's approved, how do you get it scheduled? I think a lot of that system can be hard to navigate. So I think it's both the global level and then at the individual level as a physician of like making sure patients know how this is done and then also making sure you're advocating for them within the system as well too.
All right, thank you. Anyone else? All right, I think that wraps it up for Dr. Pandya's talk. Thank you so much, Dr. P, for logging in and for presenting your talk. And take care.
Okay, take care. Thanks, everybody. Yep.